Welcome, everybody. Welcome. So it's 12:02. I think we're going to start the webinar if everybody's ready. So today we have a webinar about clinical experience with motion management using the SDX system. We have two amazing speakers today with us. We have Andrew and Zemenfes. Andrew is from New York Proton Center, and Zemenfes is the lead radiation therapist at Inova Cancer Institute. They both studied at Howard University, and they shared a common experience at the Maryland Proton Center. So today they'll give us some feedback of their experience with the SDX system. And I will now give the mic to Cheryl that will tell us about the CE credit.
So we want to welcome you, Legion Healthcare Partners, DYN'R, New York Proton, and Inova SHAR, and hope that you gain a lot of valuable experience from this presentation today. One thing about the CE credit, for everyone that registered, you will receive an email first of next week that will have a recording of this presentation along with the quiz that you have to pass in order to receive the CE credit. So look for an email the first of next week. It is standard as other CE credit in that you have 3 chances and you must pass the quiz with a 75%. At that time, you will get a certificate of completion, and it will also go towards your MDCB credit or your ARRT credit. If you don't receive that email, check your other folders. If you don't receive that email the first of next week, just reach out to me and let me know that you didn't get it, and I'll be happy to get that sent over to you. But be looking for that email with a link to the recording, the quiz, and then you'll get your CE your certificate for download once you successfully pass that quiz. So now, with all of that out of the way, we will turn it over to Andrew and Zemenfes, so that they can tell you everything they know about motion management in proton therapy.
Thank you very much, Annabella and Cheryl. Once again, my name is Andrew Okhuereigbe. I'm the lead radiation therapist here at the New York Proton Center. I'll be presenting with Zemenfes, Semaie, who's also the lead radiation therapist at Inova Cancer Institute. We'll be presenting on the clinical experience with motion management using the SDX system. A brief background about myself. I had formal SDX training at UPenn in 2017. I trained the staff at Maryland Proton Treatment Center and was the point person for troubleshooting any SDX-related issues. I brought that SDX knowledge and expertise to the New York Proton Center in July of 2019. We treated our first patient in August of 2019, and we treated our first SDX patient here at the New York Proton Center in September of 2019. In this short 2 years, we've treated over 100 SDX patients to date at the New York Proton Center, the majority of the cases being liver or left breast cases.
All right, thank you, Annabelle, Andrew, and Cheryl, and everyone for joining. I hope you find this presentation helpful. My name is Zemenfes Semaie. I'm the lead proton therapist at Inova Cancer Institute. Similarly to Andrew, I received my SDX training at Maryland Proton Treatment Center in 2017. Shortly after, became the second point person in troubleshooting and dealing with SDX, and in addition to that, training new staff as well. Shortly after, in October 2019, I moved on to Inova Cancer Institute, become a proton therapist there, and we treated our first patient. Actually, our first patient was an SDX patient in March 2020. First patient being a pediatric 17-year-old patient. So we decided to start our first proton treatment with a complicated, complex treatment, but it went well. So far, we treated about 20 to 25 SDX patients here at Inova SHAR, and recently the numbers have went up as far as our SDX treatments. We have about 4 patients on treatment right now.
A little bit lower the objectives we're going to go over today. We're going to go over what is SDX, the equipment, the SDX coaching session, the SDX simulation, SDX treatment, cleaning components of SDX, SDX maintenance and troubleshooting, and we're going to give everybody an opportunity to ask questions. So the most important thing, what is SDX? SDX is the company name for the equipment used to perform deep inspiration breath hold, or DIBH. For patients undergoing thoracic, GI, and mediastinal treatments, breath hold during treatment will cause internal anatomy that normally moves regularly with your breathing to stop moving, and as a result, allow for more precise and improved treatments. Patients undergoing breast treatment, breath hold allows the heart to move farther away from the chest wall and down lower in the thorax. This can further minimize any unnecessary radiation dose from being delivered to the patient's heart. SDX also allows us to achieve a deep inspiration breath hold technique by minimizing tumor motion or creating a greater distance between the cancer and normal organs. This ultimately allows more effective targeting of the patient's cancer while reducing the risk of side effects.
All right, now we're going to go over the different SDX components of the actual device. So as you can see that picture, that's the whole SDX device. Number one is indicating the SDX apparatus. So if we look at to the top part, that's where the patient is breathing into. So that takes in the breath. And if we look at number two, that's the actual SDX goggles. So during treatment and simulation, the patient puts on the goggles. And we're pretty much able to share our screen with the patient just like we're doing now with Zoom. So they're able to see the screen, and that's how we communicate with the patient as far as when to breathe out, when to hold their breath for treatment and simulation as well, like I said. And if we look at the device towards the bottom of the SDX system, that is the tool that we use for SDX or QA or calibration. Which is not very long. There's a 5-minute wait for the QA for the system to initialize, and the QA shortly after that takes about 5 minutes. So I would say 10 minutes in total. With an addition to that, if a full calibration is needed, it takes about a 20-minute hold for a wait time to initialize, and then shortly 5 minutes after to do the full calibration. So that is what the SDX system looks like. All right, addition to the SDX system, these things need to be ordered and they're used daily for the patients, and they're disposed as well. So we have 3 components to it. That's a mouthpiece, nose clip, and goggles. So I actually have a couple with me today. So this is the mouthpiece that the patient takes into. You guys can see it has 2 prongs at the bottom. So you want to tell your patient that they're biting into this prong. So it will be teeth under, and then lips will be sitting around it, so there's no leakage of air. And then in addition to that, we have a nose clip. So you want to make sure you kind of put it on a patient like this, and the patient is not breathing, right? The whole purpose is for the patient to breathe through the system, and there's no leakage of air. And we have a third one, which is a biofilter. It's not on there, but this would go between the mouthpiece here and the actual SDX device. So this is able to, protect patients from any contagious contaminants. Due with COVID, this is very helpful. In addition to that, we're going to go over how to sterilize the SDX system and how to also disinfect it. But these are the 3 devices that you would need to order on a routine basis. That will be used for patient treatment daily. All right, if we go to the next slide. All right, so the SDX simulation is broken down into 2 parts. The first part is SDX coaching session. Within that, there's a preparation phase and also a practice round. So that is part 1. And then the next part would be the actual SDX simulation. So the preparation phase coaching session usually lasts about an hour. And then in addition, the actual scan is 2 hours. So it is recommended to schedule your SDX simulations for 2 hours. That will give you enough time to build a great model for your patient, to coach the patient and go through all the extensive detail that is needed for SDX. And then in addition with that, to do your simulation. So the better the coaching session, the better the treatments will go, as you guys would already know. So during the coaching session, as always with any patient, they're already prepped in consultation. At our center, we have these devices at every exam room. So patients are able to kind of get familiarized with the devices. And also from the physician standpoint, they discuss with the patients to see if the patient is a good SDX candidate. Those things, some things that you may consider: can the patient hold their breath for at least a minimum of 20 seconds per se? Is the patient able to see, right? Because the patient is able to put on the goggles, and it's a visual instructions that you're giving to the patient. So those are some things that the physician looks into and determining the candidate. Now, once you have a SDX candidate and they come to simulations, the first thing that you're going to do is, just like a regular patient, you're going to create a setup devices. In most cases, the setup devices are going to be some type of wing board or arm shuttle, whichever you might have in your center. In addition to that, with the immobilization devices with a vac bag, usually with the arms up above their head, as if you're treating lung or breast. Similarly, same thing with liver, mediastinum, or anything in the abdominal or chest area. In addition to that, some centers might use immobilization devices like a vac bag for the pelvis area, just to make sure the area of treatment is immobilized. So first step is always create your setup. In addition to that, just some things that you would learn as you're doing more SDX simulations. Always make sure you have the goggles on for the patient to create those grooves around the ears, as the vac bags would be very close tight. So you're able to accommodate for those. Now, as you have your patient on the table, I'm just walking down through how the SDX simulation would go. So you have your patient on the table, and now you're going to start the preparation phase. During this time, you explain to your patient that they're going to have these devices. Make sure this is sealed around, and you have your nose clip. So the first thing that you're going to do is, don't give them the goggles. The patient is just going to start breathing in and out normal. So you want to let them know the yellow line that we see on the screen is just going to move up and down with their inspiration and expiration respectively. Now, when the patient is comfortable and they take consistent breaths in and out, you just want to indicate to let your patient know, all right, take a deep breath in and hold it to the highest level. Now, at this point, the patient takes a couple of breaths in. Once they have 3 to 5 slow, steady, deep breaths, they'll take a deep breath in and go up. And then you can see the yellow line will go to its maximum level. And then the patient, thank you. And then the patient will hold their breath for about 5 seconds. You want to repeat this step for about 3 to 5 times, just so you have a great model and you have a consistent breathing pattern, right? The reason for that is the more times you do this, you're able to get a good average for your simulation and for your treatment. This way, when the patient comes for treatment, if they were nervous or they didn't understand the whole procedure during simulation, then they're going to have trouble during treatment. So you really want to take your time during the preparation phase. So at this part, we have built our model, and now we're going into the practice round. During the practice round, you're pretty much explaining how the whole procedure will go, in addition to what information they had received from the physician or nurse. During the practice round, you want to give the goggles to the patient. Now, the patient has their goggles and they're able to see the screen, right? Just to go back one step, during preparation phase, you do not want to give them the goggles. Like I said, you don't want them seeing the breathing pattern, as the patient could get nervous and change their normal breathing pattern, right? So now that they have the goggles and you built your model, now you can go over what we see on the screen. To simply go over it, when the patient is breathing in and out, you see those lines to the bottom left there. And once the patient takes 3 consistent breaths, the yellow, or I should say the orange square, will appear. The therapist will click the orange square right there, and the green band will appear at the top. And the goal for the patient is to go into that green bar at the center if possible and hold their breaths for the imaging, for the scan, or for the treatment. It's recommended, like I said, to hold it for about 20 seconds, depending on the machine that you have. Here at Inova Shaw Cancer Institute, we have IBA system. So our CBCT takes about 42 seconds to complete, versus in New York, they have ProBeam and their CBCT is a little bit faster and shorter. So it all depends. Now that you have your model built, the patient is coached correctly, you move it into your actual simulation. If we go to the next slide. All right, so during the actual sim, it's pretty much very standard. There's really nothing different that you're going to do. The model was built during the preparation phase. Training was done. Devices were created. So at this point, it's pretty much scanning your patient in that breath hold. So as we said previous in the slide, once everything is connected, you have your patient breathe in and out as normal. Once the green bar appears, you want to communicate with your patient at this time verbally, in addition to them seeing the actual screen, just because they don't have that experience of every day of treatment. So you want to indicate your patient, all right, whenever you're ready, take a deep breath in and go into that green bar. Once they do so, you're able to start your scan. And depending how long the area or region of interest in treatment is, your scan can vary between 20 to 30 seconds. So you want to let them know, hold it as you can. And once you complete your scan, then you let your patient to go ahead and breathe out normally. With SDX, you are still able to do any type of contrast scanning or oral or IV, whichever, or you just have to time them properly so that when the patient is in their breath hold, you start your scan with the IV. All right, we can move on to the next slide.
Roughly 2 weeks after CT simulation, the patient will come back for their SDX treatment. At the New York Proton Center, the average scheduled SDX treatment time is 45 minutes. This can vary from center to center, and it's dependent on the number of treatment rooms the center has and beam wait time. It's very important to note that a patient is positioned the same way they were during CT simulation. Also, the same devices used for patient CT simulation are the ones used for the CT for the SDX treatment. During proton radiation administration, the patient is instructed to hold their breath in the green bar for at least 25 seconds. As we stated in the previous slide, the New York Proton Center, we CBCT our SDX patients every single day, and the average time it takes for that CTT is about 25 seconds. And we want to make sure the patient's in that breath hold during that imaging process. The radiation beam turns on when a patient holds their breath within that green bar. The number of breath holds per treatments depends on the radiation dose and how long each breath hold ends up being. Generally, 15 to 20 breath holds are needed for most radiation treatments. Both NYPC and Inova have auto gating. As a safety measure, the beam is gated and automatically turns off if the patient falls out of the green bar. Another important thing to note is that auto gating only refers to the patient's treatment. During imaging, we typically turn the beam on and off for imaging, but during treatment, if the patient falls out of that green bar, auto gating allows the beam to automatically turn off. Next is a visual example of what a patient sees while they look through the video goggles and while they're on the treatment table. As you can see, arms are up, the mouthpiece and the nose clip are in. And the therapist and the patient see the exact same things in these, that's shown in these goggles. The patient is taking normal breaths. As you can see, as the patient is moving, the tumor is also moving as well. After 3 consecutive normal breaths, we signify that the patient is going to that green bar. At that point is when we deliver the radiation beam. As you can see, while the patient is in that green bar breath hold, the tumor is not moving. Once the patient continues breathing normally again, we wait another 3. Once they have another 3 normal breaths, we signify that they can go right back into that breath hold green bar, and that's when we deliver the radiation beam. Of course, the patient is not able to hold their breath for the entire day treatment. On average, like we said, we want the patient to be able to hold their breath for 25 seconds. The longer a patient can hold their breath, the quicker we can get through treatment. I'm going to run through this video one more time. As important as it is for a patient to be able to hold their breath, it's equally important that they're not visually impaired. The goggles are The signals on the goggles are very important for a patient to understand what to do next when it comes to breath hold. If we have a visually impaired patient, they might not be a good candidate for SDX treatment. As Z said it earlier, during the SDX coaching session, they're instructed to know what these red lines indicate and what this green breath hold bar means. Throughout treatment, it gets to the point where we don't even have to speak to the patients about what to do next. They automatically know that when the green bar comes up, they can hold their breath inside that green bar, and if they need to breathe, they can breathe. We will only be imaging or delivering radiation when the patient's in that breath hold level. Cleaning components of SDX. The SDX system actually can be cleaned with non-alcohol or low-alcohol wipes. The video goggles is very important to clean disinfect this in between every single patient because that does come in contact with the patient's skin. They're cleaned and disinfected with low-alcohol disinfectant wipes. The honeycomb tube. So the New York Proton Center and Inova have a slightly different way of cleaning and disinfecting this honeycomb tube. At the New York Proton Center, we have four honeycomb tubes in rotation and 2 SDX devices. When a honeycomb tube is being used on a patient, the others are being soaked inside of a disinfectant solution for about 10 or so minutes, dried off, and then they're used for the next patient. So we always have a honeycomb tube in rotation. If one is being used on a patient, the other is being soaked and getting prepped for the next patient. I know Z will speak a little bit more about the cleaning technique used at Inova.
Thank you, Andrew. Like Andrew said, as far as cleaning equipment or ways to clean the SDX device is very similar to disinfecting any type of treatment device that you would have. The only difference would be the honeycomb. And the honeycomb, and especially now with COVID, is very important to clean. We have 2 ways of doing it. One way, we have the luxury of being connected and working with the hospital. So we have a sterile processing department. So we're able to just take that honeycomb up there and they get it clean and have it ready for the next day. In addition to that, we also have 4 honeycombs as well. So whenever we have 4 patients or less, we're able to just use 1 honeycomb per patient. And that's just simply labeling the honeycomb with that patient's name and having them in a slot. So whenever that patient's there, we're able to use the same honeycomb. So 2 ways that you can go about it, either sterile processing if you have that in your department, or labeling the honeycomb per patient, or like Andrew said, purchasing a solution that's very fast that can be cleaned in 20 to 30 minutes. So very important to disinfect.
Another thing I would like to add is just the importance. I know we spoke about it earlier, but making sure we have enough inventory things in stock. We order nose clips, mouthpieces, and filters on a regular basis. If there's ever a shortage, we can reuse the nose clips for patients. We label it and put it into a little box for patients to use every day for treatment. But it's very important to make sure that you're fully stocked and ordered with these supplies. Next, we'll speak about the SDX maintenance and troubleshooting. The auto gating box is a variant product that we were given to purchase. At NYPC, we designate 1 room for SDX out of the 4 gantries that we have. At Inova, they designate 1 room out of the 2 gantries they have for SDX patient treatment as well. All rooms are compatible and able to treat SDX patients, but for scheduling efficiency, it makes the most sense to have all of your SDX patients scheduled in the same room. At the New York Proton Center, we try our best to schedule SDX patients back to back. It helps with the room turnaround time, and we're able to treat our SDX patients quicker. We're treating them right after each other. External IT support is encouraged to help troubleshoot SDX issues as well. The display settings on the laptops and the monitors need to be configured to support the display capabilities of the goggles. Cables, the goggles, and wiring might need replacement over time because of wear and tear. And also an extra set of goggles is recommended. We have 3 goggles here at the New York Proton Center, even though we have 2 SDX machines. If there's ever any connection issue with one of the goggles, we just pull out the spare, so there's no delay or interruption in the patient's treatment in any way. It's also important to know that software and database updates do occur regularly with the SDX software. We work with our physics team and our IT team to make sure that we're on top of these updates and there's no delay in a patient's treatment because of these updates. At NYPC and Inova, although it is rare, patients sometimes are not able to reach their breath hold level when they come in for treatment. I'll speak specifically about a situation that happened November of 2020 last year. We had a patient, we were treating her chest wall. During simulation, she did great. She was able to lay on on the simulation table and was able to hold her breath for about 43 seconds. She was a really good SDX candidate. 2 weeks later, when she came back for SDX treatment, her first day of treatment, although she was scheduled in a 45-minute time slot, her first day of treatment took an hour and 50 minutes. She just had a really, really hard time getting to that breath hold level that we established during CT simulation. She would reach it probably once out of every 8 or 9 attempts. Usually, for the first day of a patient's SDX treatment, we try to schedule for about an hour just to give them extra time to get reacquainted with SDX software and system, since it's been about 2 weeks since their CT simulation. That same patient, on her second day of treatment, treatment time took about an hour and 25 minutes. At this point, our physics and dosimetry team reached out to the patient's primary oncologist and started having discussions of a possible resimulation. If that had been done, the patient would have had to be put on a break while they create a new plan, and she would have to be brought back in to have a simulation done again. I suggested to our physics and dosimetry team that we lower her breath hold level about 80% because it seemed like that was a level that she could reach comfortably. With that being done, I lowered the breath hold level on her third day of treatment. We took our CCT and KB images. I made sure to call our physics team over to look over the images to see how that day's images compared to the images taken during her CT simulation. They looked at the images and reached out to the patient's primary oncologist, and they all decided that the images looked good and that there was minimal anatomy change compared to that of the CT simulation date. We ended up treating the patient that day, and she was much more comfortable holding her breath at that level. Immediately after treatment, we brought the patient into our simulation room so she can have a verification scan. This scan was done, and images were sent to our treatment planning team, and the patient's primary oncologist and our treatment planning team decided to continue treatment as is with that new lower breath hold level because, like I stated earlier, the patient's anatomy did not change much at all. Because we were able to lower that breath hold level, the patient did not have to take a break, and going forward, her treatments only lasted about 45 minutes compared to the hour and 50 and hour and 20 minutes that it took the first 2 days of treatment. So like I stated, although it is rare, sometimes we do have to lower that breath hold level. This could be caused by different reasons, whether it be cancer progression, pain, or patient discomfort. We create the breath hold level at a slightly lower level, but a manageable inspiration zone. We contact the patient's primary oncologist, our physics team, and our dosimetry team to let them know exactly what we're doing and make sure we work with them so we're maximizing and getting the best out of the patient's treatment. Right after treatment, we do perform an eval or verification scan with the patient in this new breath hold zone for our treatment planning team to look at and monitor and see if any type of replan is needed.
All right. Similarly, like Andrew said, although a great simulation can be done and a model can be built exactly to the way the patient breathes that day, during treatment, for whatever the reason may be, a patient might not be able to reach their threshold as the patient can get tired or the tumor can progress. So one example very similar to Andrew that I can give is actually 2 days ago. It's very important for patients to have quality assurance scan through treatments, and our physics team and dosimetry team recognized that the threshold needed to be changed for a certain patient. So the next day when the patient came in, our physicist was present at the machine. So what we did is we had to increase our threshold in this case. So we took one CBCT at his normal threshold, which was 1.4, I believe. and we see the diaphragm is not lining up correctly. So we increased the threshold to 1.7, and we took another CBCT. And from that CBCT, we're able to see that the threshold needed to be increased to that level from 1.4 to 1.7, and the patient was able to line up much better. So we treated that patient that day, and we're able to continue using that new threshold with an addition to getting a QA scan, make sure everything looks good. So just like Andrew said, instead of putting a patient on break to do a resim, sometimes you might just need to play around with the threshold. Of course, it's very important to communicate with the physician, physics team, and dosimetry team to make sure everybody's on the same page. But however, these things do happen. Although it's very important to take your time during the prep phase and the coaching phase to make sure you have a great model. It might not be because of the practice session or the coaching session that the breathing threshold has changed. It might just be due to the patient progressing, whether it's the disease or whether the patient's getting tired or any other reasons. You're able to adjust the threshold to get a better treatment and a better scan. Mm-hmm.
Just to add to that as well, you just have to be mindful also with your communication with the patients. Usually on a patient's first day of treatment, it's normal for it to take a little bit longer. It's been 2 weeks since their simulation, and sometimes they just need a few more minutes and just a little bit more hand holding so they're aware so they can be aware of exactly what to do for that treatment. I've seen patients start off on their first day of treatment and take an hour and 20 minutes. But by the time they've reached halfway through their treatment or by the end of their treatment, they're finishing treatment in 30 minutes or less. So it just goes to show that once the importance of that coaching session and of that CT simulation session, just to make sure that the patient is able to do, number one, is a good SDX candidate, and number two, is able to hold their breath and can see through the goggles throughout the entirety of their course. There are situations in which a patient is not an SDX candidate. In that case, we make sure we let the patient's primary oncologist know, and we do not use SDX for those patients. And now at this time, we'll open the floor to any questions that the audience might have.
Thank you very much, Andrew. Thank you, Zemenfes. So if you have any questions, please put them in the chat and we'll answer them.
We do have several questions. One thing I wanted to ask Zemenfes, I know that we discussed this when we were doing our preparation different sessions, and one of the statements that came up is sometimes children adapt better to the SDX than adults, and you said that you had quite a bit of experience with pediatrics. Do you mind to go into that just a little bit, and then we'll get to some of these questions? We've got several questions out there.
For sure. Oddly, you would think maybe adults understand the system better, but these days, children are pretty savvy as well when it comes to the technology. So at Inova SHAR, what we have is we have a guide that we send to patients even prior to their simulation, so they can use that tool to practice. So it's very similar to playing a game. It's essentially using just the arrow up and arrow down to play around with the system. And then once the patient gets into that breath hold, and it's just using the right arrow to kind of continue using that system. We really take our time with our coaching session, like I said, especially when it comes to pediatrics. One, the simulation is done in 2 hours, so that gives the patient a lot of time to understand the system. And then in addition to that, we have a play date, depending on the patient, if it's needed. We also have a child life specialist, so they're able to see if that specific patient needs any extra coaching sessions. They're able to bring the patient to treatment, and depending on our schedule, we just show them around the treatment room, show them around the system. They kind of get familiar with it, so they're able to do much better with the system. And we had many patients, mainly pediatrics, that were able to hold their breath for a minute and 5 seconds, so they're able to hold it for the whole entire beam. Like I said, our first ever Proton patient at Inova SHAR was a 17-year-old pediatric. He had one beam, and he used to get it done in about 35, 40 seconds. So you'll be surprised how much the kids are able to understand and use the system.
Thanks for that, because with my history in pediatrics, of course, that's what I always want to know. Since you mentioned time, one of the questions that came in for either of you is, how did you decide on that 25-second mark? Where did that standard come from? Is that trial and error? Where did that time come from?
Yeah, I can speak a little bit on that. So for our SDX treatments, we do a CBCT every single day. Of course, during the imaging process, we want the patient to be in breath hold while we do that imaging. The minimum amount of time our CBCT takes is about 25 seconds. So that's a requirement for our SDX patients. We want them to be able to be completely in breath hold the entirety of that CBCT image. So that's why we have that 25-second threshold. On top of that, it's important that the patient holds their breath that long, because the longer the patient holds their breath, the quicker treatment can be. If a patient is unable to hold their breath for a long period of time, they can end up being on the treatment table for over an hour just because of the difficulty they're having.
Yeah, it's very similar for us. The guidelines that you're going to use to come up with the minimum time required to hold your breath all depends on treatment time, how long your CBCT is going to take. Our CBCT takes a little bit longer. The patients are able to breathe out during the CBCT. You can pause the CBCT and pick it back up the second time. However, if there's many pauses as you're doing the CBCT, then when it does the reconstruction, your image quality is going to decrease. So it's really recommended 20 seconds or higher during that. So, and this is evaluated by the primary physician during consultation. So we're able to get good candidates that will benefit from the SDX treatments. That's a great question.
Another one of the questions that's come in, and maybe you have experience with this, and if you do, describe that experience. What about a patient that requires a mask? Can you use the SDX system? And if so, what does that look like?
That's a really good question. So we are able to treat SDX patients that require a mask. I actually worked with our physics team. We created an apparatus that we can put underneath the ball frame. You have to be very systematic and strategic about how you set that patient up. You put it underneath the ball frame, and it's put on one side of the patient so it can still hold and house that SDX module, and it's close enough to the patient's open area of the patient's mask that they can still get their breath holds in and look through the goggles. So there has to be an opening around the nose and mouth portion of the patient's mask, as well as an area around the patient's eyes where they can see the goggles. But it is very possible to treat a patient that has a brain or head and neck mask. Yeah,
like Andrew said, very possible. Same thing for our center. It's very dependent on the type of device that you have. At New York, Andrew was able to help create a treatment setup for this case. At our center, we have 2 different tables that we're able to use for treatment. So we have a space over the patient's head to put the SDX apparatus that's going to go into the patient. So like Andrew said, it's very different as far as the setup is concerned. It might have to be something in-house that's built that works for your center, but very possible you'll have openings of the mask for the nose piece and then mouthpiece and nose piece as well. So very possible. And I think we treated about, I would say 5 patients that you're treating mediastinum, and that goes into the C-spine as well. So very possible, yeah.
So another question that I think really speaks to the knowledge and experience that you two are bringing to the audience today, but somebody wanted to know, do you always have to have an SDX expert in order to treat the patient? So how do you do that? Is there always someone who's very, very familiar with the system? Is everybody in the facility familiar with the system? How do you team those folks up?
Really good question as well. I've been fortunate to be in a situation in which we were trained, and we were the ones training other staff. And as we continue training other staff, of course, our knowledge will increase as well, especially over the years. It's been over 4 years now that we've been using this SDX system. The most important thing is it is training. We worked at Maryland very, very closely, even here as well, with our physics and our physics team. At least we have at least one point person on the fitness team that's very familiar with SDX. Once you have a core team of people that are familiar with the system, then it's easy to start training other staff. Even throughout, the course of treatment, issues might arise with SDX. It is important to have that point person or at least a team so the therapists can go to when they have these SDX issues. So formal training is important just so you're able to answer all the questions and you're able to, in real time deal with issues related to patients' SDX treatment without having to delay their treatment.
Yeah, great question. Like Andrew said, very similar. We do have a point person from physics standpoint that was able to, train staff, and we're able to train staff as well. In addition to that, we have competencies that we keep up to make sure everybody knows how to use this system. But the system is very, very easy to train. So once you have a couple of practices and you're able to participate and observe a treatment, you shouldn't have a problem using the system. So very easy to use, like I said.
Good, and I'm glad you brought that up about competencies, because that was another question. Somebody said, how do you know that somebody's an SDX expert? So I'm glad that you brought up that there are some standards that your facility follows. Another question that's come in a couple of times is, what about rotations? What about couch rotations or gantry rotations? Does it work the same way? Do you have to replan in these instances? So can either of you address that?
I would say rotations. We haven't treated any patients with couch rotations here. I remember at Maryland Proton Treatment Center, we had one patient, I believe. But as far as couch rotations, it can't be very much, just because the SDX apparatus being on a patient has a cord that's going to go into the SDX trolley. So you're able to move the SDX with it, but it's not more likely that you're going to have those type of patients. It's doable, but you just have to be very creative. And depending on the type of system that you have and the type of couch that you have and the movements, you're able to do it, but it's very limited as far as many couch kicks that you might have versus a patient that's not an SDX patient.
Just to piggyback on what he said, I think I've only seen 2 patients with SDX that have used couch kicks over these past 4 years that I've used this system. It's doable, of course. The way the wiring is set up, we can be creative and connect the wiring and the cords to the table or table to the table and move that SDX module as we go from one gantry angle to the next if there's couch kicks. So it is doable, but we don't usually see that in treatment plans made for SDX patients.
So one other question we have here is, you talked a lot about deep inspiration breath hold, but what about the literature that supports expiration or exhalation breath hold for like liver lesions? Do you have any experience with exhalation breath hold? And if so, what has that experience been like?
Good question. So at Maryland and here at the New York Proton Center, we've never treated a patient with expiration breath hold. It is possible, but with working with our physics and dosimetry team, that hasn't been an avenue that we've gone yet. But the system is capable of doing that expiration breath hold, so I do not have experience with that.
The same. We haven't done those type of treatments. But good question, though.
That is a great question, especially for liver, which is what they specifically asked about. One other question, and I think, Andrew, you addressed it a little bit and said at New York, you schedule about 45 minutes for patients. And I know Zemenfes, it's a little different for you. So someone wanted to know, how do you do those schedules and how do you make those the most efficient?
So yeah, many things go into determining that 45-minute time. The biggest thing is how many gantries you have in the facility. We have 4 gantries here at the New York Proton Center. So we have to keep in mind patient beam wait time, as well as, how long it takes for a patient to actually get into that breath hold on a regular basis. And we determined, when we first started treating patients, we started scheduling them for an hour. And then as time went on, after about 4 or 5 months of learning the system and learning how to schedule efficiently, we started scheduling SDX patients back to back. And we've also worked on we've also worked on making, the treatment a little bit more efficient. We step out of the room now when we do our SDX treatments, and we just go in just to, do a clearance check of the CTT or check to see if the patient's okay. But we do all of our imaging now outside of the room, which makes things a little bit quicker. Of course, we have a staff that we trust and we've trained in one of our gantry rooms that's aware of everything that needs to be done for SDX treatments. But because of the number of gantries we have and beam wait time, we determined that 45 minutes is the best time. We've gotten a lot of data from our physics team, and on average, SDX patients are being treated around 40 to 43 minutes.
So do you have anything to add to that about scheduling or about how you decide which patients go in what order?
Yeah, like Andrew said, depends on how big or small your center is. In our case, we have 2 treatment rooms, so the beam wait is not as long as it would be at New York Protons. In addition to that, also depends on the actual plans as well. So most of our SDX plans, they have about 2 to 3 beams, and each is about, I would say, 20 to 30 seconds long. So we're able to schedule them in less than 45 minutes. So it truly all depends on, how big, small your center is, the actual treatment plan, and your beam weight. So it's a little bit shorter for us since we have 2 rooms.
I believe that gets us through all of those great questions, and those were some excellent questions at the end, which means people were really, really thinking while you were doing the presentation. So importantly, I want to thank you two for taking time out of your very busy days to do this presentation with us, and to thank all of the attendees. We had a large group today. If you have any questions about the system, reach out to Annabelle at DYN'R. She can give you her contact information. If you have any questions about anything else that's going on, if you need me to get you in touch with anybody, you can reach out to me at Legion Healthcare Partners. So Annabelle, I will let you close this out and give your information so that folks can reach out to you. She's put it into the chat box, her email address, so that everybody, if you have any questions, if you want to see a demo of the system, if you have some more questions that you think of later, clinical questions, reach out to Annabelle. So Annabelle, I will let you finish this out, and we will let everybody get back to their day.
Thank you, Cheryl. Thank you very much to our speakers, Andrew and Z. It was really nice to have you here today to give us your feedback with the SDX. Like Cheryl said, if you have any questions, feel free to reach out. We can even put you in contact with Andrew and Zemenfes. So we hope you liked the webinar, and we'll see you soon. Thank you, everyone.
Thank you.
Thank you all. Have a great day.
Bye.
Bye.